right, good morning, folks. We're going to go ahead and get started. This morning we have Dr. David O'Neill, one of our own, and he's going to be presenting about rural medicine. Those of you who are in Tanglewood, please come down and visit because it looks awful rural in this conference room right in the morning. And we want it to be an urban talk on rural medicine. A little bit about David. David was born locally in at Roanoke Community Hospital and grew up in Blacksburg and Floyd. He moved to Tennessee with his family in middle school out in the Oak Ridge area. So spent a little time there and did some work at Oak Ridge, I believe. Driving down from Bent Mountain to Roanoke to see a pediatrician, it gave him the appreciation of the difficulties with access and really has kind of laid that foundation for his career in pediatrics. He returned back to Southwest Virginia for, where else? Virginia Tech. Got his degree in chemistry there. He got into a little bit of nuclear chemistry, moved to Roanoke where he completed at med school at VTC, School of Medicine, and he stayed on during his residency. And I'm excited because he's staying here within the Roanoke Valley area as a general pediatrician working within our Rocky Mount office. David had to outdo me. I was a native of Blacksburg, had to get my undergraduate at Tech. Now I'm on faculty and interim chair at Virginia Tech School of Medicine. So he's already a triple Hokie. Now he's going to stay on and be faculty just to outdo me. So David, tell us a little bit about rural medicine.
All right, so as we get started with my talk, let's see if we can just advance. There is a link in the chat if you guys want to do it while we're going through some of these intro slides, just for a word cloud activity, just talking about some of your thoughts on rural medicine. And we'll have another slide where we can do that, but there should be a link in the chat already for you guys. I'm talking more about challenges of rural medicine. I have to give a big shout out to Dr. Stephen Griffin, who acted as my advisor. He is probably the most rural pediatrician that I know working in eastern Montana. And so I really appreciate his help with some of the ideas of what to look into for the challenges of rural medicine. I have no relevant financial relationships to disclose. I do have a disclaimer in here that a lot of the research when we look at rural versus urban is going to have inherent generalizations within it. So when we look at it, right, we're also looking at all different factors beyond just the,
there's no link. There's no link for us.
Maybe if I join on my phone, then
you might have to join the meeting to see it.
Join and then unjoin.
in Teams, right? We're in Teams now. We don't use webcams anymore.
All right, we'll get the link popped up for you, and if not, we'll have a QR code on that for you. But just with rural medicine, no two communities are exactly the same, so we have a lot of generalizations built into this topic. All right, so a quick outline. We'll have the next slide. We'll have the QR link on it, getting your thoughts. We'll go through a historical perspective on rural medicine, looking back at some of the challenges people have seen over the last quarter century or so. Talk about access a lot, because that's one of the big challenges there, both from the primary care standpoint as well as from the hospital side of things. We'll talk about some of the special concerns and health disparities for rural populations, and then talk about maybe some of the solutions to help address these issues with a focus on telemedicine. So here is the QR code link, if you guys don't have it, and then we can get you guys put. So again, the question is, what do you think of when you think of challenges to rural pediatrics? Hopefully it will scan for you guys. You can also type in the address right here. The texting thing does not work well. I don't recommend the texting option. Maybe make it bigger if we need to too.
Make it big.
Should we do multiple one-word answers?
Maybe multiple one words, yes.
Okay.
I'm
So
sorry.
make this bigger. Oop.
There you go.
If that'll work.
Well, there you go. It's not good.
Alright. Switch over here. Oops, sorry, do you still need it? There you go. Alright, no problem. Alright, awesome. Thank you guys for putting these in. So here, I think, yeah, we see a lot of things, right? We see some access here. We're talking about getting enough care. And enough, I think, is really a big thing, right? Is there enough resources, enough doctors, and enough support for all these things. Yeah, there can be difficult things there for sure. Let's see. Everything's a challenge, okay. Yeah, awesome. Inappropriate specialists, yep, getting access to specialist care is all good. All right. Inappropriate injury, yes, it's definitely something you want to be careful of, right, is making sure that we give good high quality care in places, even if they are rural. So that's really, really good there. All right. That's good. I'll go ahead and stop this for now, but thank you guys for participating. I agree with a lot of these things that are popping up, and hopefully we'll be able to address a lot of these challenges throughout the rest of the talk. Let's get back into the PowerPoint. All right, so looking back to 1995, there was a study looking at the challenges of rural pediatric care. And this was a small group that had a regional network of outpatient offices that did a survey of their patients and also the providers at those places. And so when the patients made their list of what they want, this is not the doctors, this is just people in the community, what they were thinking was important. Mental health care and counseling is one of the biggest challenges that people face. Getting the access to mental health. And we're still seeing some of these challenges with substance use disorder now. Less so back in the 90s, but still an issue that people are talking about. Gynecologic and obstetric care. I think we've all seen challenges getting kids in with OBGYN, even locally, especially after Dr. Laboratory left. There's some turmoil within the department of who's going to see the youngest kids when they need help. Dental care was a challenge, specialty services for children, getting access just to primary care, and especially primary care that accepts Medicaid was a big challenge. And then also adequate transportation to and from healthcare facilities. And that's just what patients were seeing in 1995. If we look now from the physician side of things, right, they also talk to physicians. So one of the biggest burdens rural pediatricians were facing was that call frequency. If you're the only pediatrician in your group, you're the one who's on call all the time unless you have a deal with someone else who can cover you. Another thing is that a lot more rural pediatricians are doing more of that traditional model where they also provide either ED consultations or inpatient coverage as well. So your call might not just be, we have the nurse triage it, here's the bilirubin level, what do they need to do? It might be, we need you to come into the hospital right now, someone's delivering, there's a kid in the ED that's crashing. And so that can definitely be a burden that adds up on people. It's not just answering the phone when you're on call. You might be running into the hospital at all hours of the night, multiple days a week. So that's one of the big things. There's also limited specialist support, especially when you have those sick kids, right? You end up in a mess, it can be hard to get someone to help bail you out. Help can be far away and take a long time to get to you. Community expectations. So a lot of people felt like when they're in these community, they kind of have to be at the highest, role model for everybody, and every little thing they do can be scrutinized by the community. Hospitals like saying that they have a pediatrician involved in a lot of their committees and work groups, right? If you're the only pediatrician around, that means you're getting asked to join all the different committees and have a lot of the hospital expectations. They want your input on all these little things just to say they have the pediatrician involved. And so you might be asked to join a lot more of the system operations side of things on top of caring for all the patients and being on call. And then a lot of times the rural doctors felt like, the people living in the cities at the bigger academic centers kind of look down on them and view them as inferior or not as good. And so then you're doing all this extra work and people aren't really valuing it. So those were some of the challenges back in 1995. So then my question is, right, how far have we come from 1995 in terms of addressing these challenges? I think many of those same challenges that patients were seeing, we're still seeing, right? Getting in with doctors is still hard. Dental care is hard to find. Getting transportation, we don't have a great system. Some systems can help get, Medicaid taxis and things like that, but it can be really hard for those rural pediatricians and patients to get to the pediatricians. On the flip side, I think some of the things from the physician standpoint may actually be spreading beyond just rural areas now. With social media, mommy boards, and all of those things, I think even pediatricians living in urban areas have their image can be attacked easily, and then the whole community in the city can be seeing good or bad what they've done. So those challenges I don't think have gone anywhere. So what can we do then to further address those as part of the question? All right. So I have a bunch of maps in this next slide looking at numbers, just talking about access of care. So this is looking at the US in terms of board certified pediatricians. We have both the specialists and general pediatricians included in this map. And if you look at the national average, it's about 75 pediatricians for every 100,000 kids. If we take out the specialists, that number drops to about 65 general pediatricians for every 100,000 kids. And those kind of numbers generally stack up. So about every 6 out of 7 pediatricians are general pediatricians, if you look at the different numbers. So if you look at this map, though, we do see pretty big regional trends. If we look on the West Coast, they're doing pretty well. They got some good blue out there, and the Northeast is a dense blue color. Where we see more of the problems in the South and then the Midwest and Mountain West. And what do we think about rural areas? Where do we see most of the rural areas in this country? The Midwest, Mountain West, and parts of the South as well, yeah. So even just looking at this map, we can see that rural areas can have pretty significant disparities in terms of just the number of providers that are in those areas. I'll zoom in now on Virginia in particular, right? So this is again looking at by a county map. Remember in Virginia, all cities are technically their own county, so that's why we have all these little bubbles here. Roanoke City would be that one right there. And this is just looking again at board-certified pediatricians, both specialty and general pediatrics. It's interesting that Salem's a big white hole there.
I was just gonna ask, what is that?
And that's because a lot of the Lewis Gale, right, provides a lot of care. They're actually located in the county, technically.
What is that last one, the blue?
This one, this is down near Bristol.
That's Washington County.
Oh,
Yeah, Washington County surrounding, Bristol's the little white dot, but so in the county here.
Abington.
Yeah. And it's like Johnson Health Center and stuff is down in that county. Yeah. We also though see though, right, even just looking at the zoomed in map, even in a state that's doing okay like Virginia with 78 on average, right, we see big areas where there's no pediatric care, right? And a lot of those are in that more rural south and then southwest of the state. When we look at the north, there's a lot of white, but that's because a lot of the pediatricians would populate in those cities locally, so they might not have as far to go to pediatric care.
I just got to poke, you look at the Roanoke Valley area, and, you know, we've got about 350,000 between Roanoke, Salem, Vinton, Roanoke City, Roanoke County, all that. And that would imply that we've got 240 pediatricians or more.
But is that also looking at people who are double boarded? Still keep
Might be does it include family medicine at all?
So this is not, this is just general pediatrics. So if you hover on like Roanoke County on this map, they say there's 14, I think, pediatricians in Roanoke County. Part of this will be based though too on where your licensure says your main office site is, right? So this does not capture people who are traveling, right? People who go down to Martinsville for a clinic or go to, you know, Lynchburg for a clinic from our specialty here. They're not going to show up as a Lynchburg pediatrician even if they might be spending time there. And like if you look at Franklin County, right, it says there's no pediatricians, but we know that we have Carilion Pediatrics down there, but a lot of those people aren't having that listed as their work site in the healthcare system. So they might be listed at the main Jefferson office for Carilion, for example. So people who aren't in big systems might not show exactly where they're working, but this is just a good big picture overview.
And then the specialists keeping up their, who are keeping up their Gen Peds boards, if they're double.
It should still count once.
Okay.
But yeah. Now, if you look at the map from Montana where Dr. Griffin is, right, if you look on like the eastern third of the state, there's only 4 pediatricians in the whole eastern third of the state. Right, so he definitely is far more rural than we are here where we have dozens, even in these more rural areas. But
Which state is that again?
Montana.
Okay.
Yeah. All right, I have one more map here. So now this is looking beyond just pediatrics. This is looking at primary care shortages overall by county, based on the federal health designations, right? On areas that are a shortage versus partial shortage or non-shortage, right? So looking at this map, we can see that Roanoke City, the whole city is listed as a shortage area, even though around it is not a shortage area. And that's because a lot of times the pediatricians that are providing care to Roanoke City are located, or primary care doctors for Roanoke City are located in the county around it. So like technically we're in county here, right? Even though we're Roanoke pediatricians. So. That's just an interesting map too, though, looking at the healthcare shortage areas by PCPs. And so that I looked a little bit more, right, to see how bad can this be across the country. And there was a 2020 study looking at how many counties don't have a pediatrician. And that number has increased over the last 10 years, from 2010 to 2020. So now we have about 1,100 counties in this country that don't have any pediatricians in them. Is family medicine picking up all that slack? Well, 330 of those don't have family medicine or pediatrics located within them. And those numbers are both going up. When we look nationally, we have more pediatricians and more family med doctors than we did in 2020 compared to 2010, but less of them are in rural areas. So, putting that in perspective, how many counties are there in the country? Any guesses? A little bit over 3,000. So, it's about 1/3 of the counties in this country don't have a pediatrician.
I would guess way more.
Yeah. Again, how some states count cities might factor that a little bit, but roughly speaking, a little over 3,000. So that was looking at outpatient primary care pediatrics. We can also look at the inpatient side of things. So this was a study that made a lot of news when it came out in 2021, talking about the shrinking number of pediatric beds in the country. And it was a study done by Cushing et al. She was a pediatrician who then went on to do an emergency medicine fellowship, actually, and looked at these changes in access to care. So when we look across the board, we see generally a decrease in the number of beds. I think it shrunk by about 16 to 20% the total number of pediatric beds in the country. A few areas did see increases, so Montana, Kentucky, and Oklahoma all saw, pretty good increase in the percentage of pediatric beds that are available. But by and large, we're seeing a shrinking access. When we look at Wyoming, there was a big drop there, and when that unit closed, it actually became a whole big hole in the Dakotas, parts of Montana, and Nebraska, where now they have to travel extremely long distances to get to care. So there's a big desert for pediatric inpatient care in that area, looking at the map. And so this is, we talked about the pandemic forcing closures and made big news when big Northeast program closed, a couple years ago during the pandemic. But this was all 2009 to 2018 data, so all pre-pandemic that this was happening. And the pandemic's only accelerated that. We don't have great numbers in terms of the exact numbers now in terms of pediatric beds, just because some places are reopening, some are using alternate use of their beds during the pandemic. So it's a little bit hard to get the good data post-pandemic, but it's only been a worse problem in general. Interestingly, PICU beds have actually increased in the country over the same time. So they've gone up about 16%, the total number of PICU beds in the country. But almost all of those are localized to those regional academic centers. So it's not getting more PICUs, it's just bigger PICUs where there already were some. Yeah?
Is that only identifying pediatric-specific beds?
This is pediatrics only.
Because just a lot of the community hospitals are flex beds, they'll...
And that's where it gets harder,
yeah,
especially after the pandemic.
Med surge wards that take anything.
What about med-peds? They still get peds admitted under peds, I guess, right?
Yeah.
Yeah, but these are designated pediatric beds and pediatric units. All right, so this is another graph from that study showing where people had to travel further to get to their clinic. So it's a little bit confusing. At the top, we see people who are now closer to a pediatric hospital than they used to be. Right, so you see a few, maybe up to 15% might be a little bit closer to a pediatric bed, but the ones who are closer are only a little bit closer for the most part. On the flip side, when we look down here at the places that are farther, right, about 25% of kids are farther away from a pediatric hospital than they were 10 years ago. So that's concerning, right? And if we look at the areas that hit the hardest, it's actually the micropolitan, followed by the rural areas. If you think about it, that makes sense. If you're in a small city and your place closes, right, you're gonna have to go to the next small city or a bigger city to get care. If you're in the rural area between the two cities, it might only be a little bit further to drive to the next city. So they've seen the biggest jump in that greater than 50-mile changes there. That said, 25% kids are further away from a pediatric hospital. All right, so then the question becomes, well, sure, they're further away, but does that matter? Regionalization of healthcare can have some advantages, right? Economies of scale, running things at bigger places often cuts down on some of the overhead costs and can lead to better access to experts who are seeing higher volume of care. So is this then affecting us in terms of the care pediatricians are able to give to kids and the care that kids get? And so this is a nice study done by that same group that looked at those last two maps that we saw. And it looked at EDs in terms of their ability to provide definitive care for these three common conditions: asthma, croup, and gastroenteritis. And what they looked at was based on the different quartiles in terms of volume that those EDs see. So if you look at that top right, the lowest quartile in that orange graph, seeing the lowest quarter volume of all EDs that were included in the survey. We have 2, 3, and then the highest here in the blue. Pediatric specific EDs, ours would count, even though it's not a standalone ED, where it's an ED within an ED, which counts a pediatric ED. And that's the green line here. It's interesting to talk about what they're talking about here is referral rates. So what is a referral rate? This is where they looked at the number of kids that are transferred divided by the total number that were either transferred or admitted. Right? So it's not getting the people who weren't discharged. Transferred is not discharged. And so what we're seeing then is a big increase, especially for asthma and croup, in terms of who is having to get referred out of that ED. Gastroenteritis saw a little bit of change, but not nearly as significant of a change as the other two. And part of the thought behind that is that when you have a respiratory illness, right, that's something that can rapidly deteriorate to something that you might not be able to handle. If you don't have the ability to, intubate these kids, provide non-invasive pressure support, high flow, you might not have any way to escalate them further. So that leaves the high risk if you're not comfortable with those modalities. Meanwhile, gastroenteritis, most people feel pretty comfortable, okay, we can give an IV and rehydrate, but even with that, we are still seeing increases in the referral rates. And so then what does that mean in terms of bottom line impact to kids, right? That means you're less likely to get discharged from your ED and more likely to end up having to have the cost of an inter-hospital transportation when you show up to your initial community hospital for care. It's interesting with this, we think, okay, well, is this just the smallest volume are rural? That's not actually the case. They broke out rural as a co-founder here and found that it wasn't actually a significant change just based on location. It's really more volume based in terms of the metric here. That said, right, lots of rural community hospitals are going to have lower volume of that pediatric care. That alone, rural alone does not explain these changes. All right, so there's some good news, right? Regionalization can be efficient. There's a 2023 study looking at pediatric surgeries for some common neonatal procedures that might be needed. So gastroschisis, tracheoesophageal fistulas, first lung disease, congenital diaphragmatic hernias, and anal rectal malformations. So they looked at this study. They had included a little over 5,700 babies getting these procedures. And what they found was that 20% of those kids lived in rural areas. And from the places where they were getting the surgeries done, they lived further away. That said, their outcomes actually tend to be about the same overall. For some of them, there's a slight increase in the length of stay. And then for tracheoesophageal fistulas, there's a slight increase in the chance of being readmitted in the next 30 days. But by and large, across the board, outcomes were about the same. And so that was maybe showing, right? And that makes sense. If you have babies that are really tough to operate on, having the pediatric surgeon who has the most experience with them probably is a good thing, right? The question then becomes, though, right, what about for more common procedures, such as an appendectomy, right? There's another study looking in the early 2000s, 2000 to 2010, and showed that high volume centers were doing about 10% more of the procedures than the lower volume centers in that same time frame. So even for those common things, we are seeing a push towards going to the higher volume surgical centers. And so it's one of those things too, again, economies of scale, but then what does that mean for the families in terms of how far they're having to go for care? Cost, right? Oftentimes money is the bottom line, right? So if it is truly cheaper to have regional care, right, you can cut your overhead and it's better, more efficient for the system, maybe we can make up for the burden to the families by arranging for transportation if the costs are lower this way. Unfortunately, we don't really see lower costs in these admissions at this time. This is the 2016 study. It used raw data from 2012, so it's a little bit old now. But it looked at a huge number of admissions, right? We're talking, 750,000 admissions almost there, 672,000. And what we see is that 1 in 8 of these admissions were for rural kids. The cost for a rural admission was about $700 more than a kid who lives in an urban area. Just accounting for length of stay, all other metrics the same, that's what they were seeing in their analysis. We also see a slightly higher readmission rate, odds ratio of 1.05, and slightly longer length of stay, by about 0.1 day. Now, those are small changes, right? But when we think about it, that can have a large impact to the system over time, right? So if we're talking 672,000 admissions, right? 1 in 8, that comes out to be about 84,000 or so kids living in rural areas, right? If you're talking about length of stay for every 10 kids, you're having an entire extra day stay. That's 8,400 extra days in the hospital just based on where kids are living. Some of that's going to be unavoidable, right? If it's 10 o'clock at night and you finish your bowel clean out, right? Your stools are clear, your KUB is normal, you can go home if you live nearby. If it's a 2-hour drive down windy roads, you're like, I'm not really comfortable driving home at 10 o'clock at night, you might end up staying in the hospital a little bit longer. But this does affect then your bottom line down the road. All right, so now I'm going to talk a little bit about some specific disparities. So chapter 2 of Nelson's, right, the kind of my ideal textbook pediatric, my go-to reference. This is right in chapter 2, right? You don't have to wait until the end. They have a table that breaks out all of the different diseases by risk factors, including rural and urban. So these are the ones that have a listed disparity between rural and urban areas. And when we look at this, right, rural traditionally outperforms urban areas in just one of these. Does anybody know which one of these rural is traditionally doing better?
Breastfeeding.
No, so it's actually in asthma. So we typically think of asthma being an industrial disease, right, caused by pollution, making it worse. That's actually changing a little bit. We're now rural kids oftentimes have severe asthma, and it might be less well managed asthma as well. But traditionally, we thought of asthma being a more urban disease just due to pollution. Obesity tends to be higher. Again, remember that map that we go back to. The South has a higher number of rural areas and also higher obesity as a whole. Right? So is it rural or is it really regional? That skews things a little bit. There's more formula use in rural populations, worse oral health in general, less frequent visits, and less likely to have a medical home. Less medical homes also means then that you often are getting care at EDs and urgent cares, further driving up costs. So another specific area that we see a lot of disparities is in mental health. So here we can see ADHD, depression, anxiety, conduct and behavioral problems, suicide deaths, and people being on medications are all higher in the rural areas. This bottom number I think is reassuring, right? Maybe these people are getting care if they are getting on medications at a higher rate. But if we look at that difference, right, if we add up all these percentages higher, we end up still not getting all the people. And it also means they might only be getting medication and not getting therapy or other treatments that they may need for their mental health. It also makes it interesting too that some of these changes might look small, but they are still higher for the rural pediatric populations. So maybe if we looked at more numbers, we'd see further trends changing there. We can also look at mental health hospitalizations in this population, and I think this is a very interesting trend, right? So despite anxiety being more prevalent in those rural populations, we've seen fewer inpatient admissions for anxiety disorders. Eating disorders are not higher in rural areas. We're also seeing lower admissions there. Depression is about stable, even though depression is more prevalent in those rural populations. What I think is very concerning, though, is that we see a lot of the admissions here are going to be for your suicidal behaviors. And when we see suicide and self-injury hospitals higher, but not anxiety and depression, it does make us wonder, are we not catching people sooner? Are we only seeing them after they've come to a severe crisis, which is life-threatening? And that's one of the big concerns when we look at this, that we might just be triaging for the sickest people in our use of those hospitalizations. All right. I'm going to do a quick focus on firearm injuries just because that is, going with the suicide, one of the greatest causes of death for kids in these areas. So 2010 looked at a large database study of rural versus urban populations. Overall, deaths from firearms were pretty similar. Urban areas tended to have a little bit higher homicide rate, while the rural areas had lower homicide and higher suicide rates when guns were involved. Looking further, though, at then the specific single site, looked at all of the firearm injuries and broke them down by different categories. And so handguns are the #1 source of injuries, right? That goes across the board for both urban and rural areas. If a shotgun or a rifle was involved, it was more likely to have happened in a rural area. So handgun is still #1, but if it was one of those weapons, it was more likely to be a rural area. About half of these injuries occurred when children were playing with the gun, right? Not trying to hurt anybody, just using it as a toy or playing with it, exploring it, curious about it. 46% of this study occurred within the house. This wasn't kids out downtown or out doing things. It was people in the home. And this is higher than the reported national average when they did the study, but again, this is a single site study. I also thought the ages were important here, right? This wasn't mostly teenagers. The average age of those being injured was a little over 9. And the average age of the people who were firing the gun, if it wasn't you injuring yourself, were less than 9 years old. And children as young as 2 had fired guns in this study and caused injuries. And I think that's something that, all these statistics, right, one thing, but this is something that you can use when you're talking to families during a well child check, right? We all ask about, are there any guns in the house? But this is what I say, kids as young as 2 can find a gun and hurt someone with it. I think here locally too, we've been extra aware of this given the first grader who shot their teacher over in Virginia Beach recently as well, has definitely put that in the news, right? Little kids are playing with guns and hurting people with guns. And so that's something that just drives home, I think, the message. And that sometimes can get families to perk up and listen, I think, when you have statistics like these. This is something that Dr. Griffin has been dealing with acutely as well. So Montana has long led the nation in terms of suicide deaths, with firearms being the most commonly used method when people died from suicide. It's something that's been ongoing despite the pandemic. It went up even more during the pandemic, but still remains high in Montana. This is an article from the New York Times from June of this year. And this is something too, right, where again we see that there's a big difference when we talk about rural areas, right? This is a big problem for Montana right now. Montana is not struggling with obesity like we were talking about with the other things, right? A lot of Mountain West in general does well for those things. But it's something to take home, right, that despite a lot of effort, we haven't really made huge progress always. And it's hard to break this egg. It's a tough one. All right, so moving on, switching gears a little bit. So some of the other challenges, logistics becomes a big challenges for pediatrics in general, right? So it's not just, okay, I see the kid, but can you see the record? If you're a small private office, right, you might not have access to Epic. Epic is extremely expensive for small offices to try and get up, and they also don't get the same level of support that bigger health centers do when they do get access to those EHRs. But can you see records? When they go get specialty care, are you able to really be that hub that balances out the family needs with what the specialists want if you can't see what the specialists are actually saying? Another problem is, do you have the tools that you need to take care of these kids? And so, right, do you have access to a lab that can get you results quickly, right? If you have to send your bilirubin 4 hours away to get read, right, it can be hard to plan, okay, now who do I need to get the lights for? What do I need to do to get people care? You have access to radiology, right? It'd be easy to say, oh yeah, I can check your ankles if you come in, but if you don't have x-ray equipment, are you going to be able to rule out that fracture, or are you going to have to send them elsewhere to get care? Even little things, right? Having the correct catheter sizes, right? To do urinalysis, do clean, catheterizations, to get IVs in kids in these small hospitals. If you don't have the right size IVs, it can be hard to give care to neonates. I'm talking with Dr. Griffin, and even heating mattresses for newborn being born early can be really tough to acquire. I think he was saying he had to get his from the transport team to get them to leave one behind for the next time that they had problems with a little baby who needed to be heated, or those preterm babies that are being born in smaller nurseries. And then the other thing is, right, is it going to be transportation, right? So you might think, okay, well, if it's a problem, I'll just call NeoPeds and they can come help me. Well, if you're hours away, it might take a long time for help to get there. Now you add in some of the challenges of rural medicine, maybe in a remote area. Storms coming through, you can't fly. You have a snowstorm, they might not even be able to drive for a little while. So now how are you going to be able to stabilize those kids until you can get further help? And having those skills is really important for rural people to be able to manage that from the doctor's side of things.
Some of the other kind of interesting tensions that you run into is there are times where you want to transport somebody by ambulance, but actually it's going to be faster to send them in POVs, but you're sending them in a POV for 3 hours or 2 hours away. I mean, one of the most common instances we run into is acute testicular pain, right? We had an ultrasound sonographer, 40 hours a week, but missed them beyond that. So even just to get the ultrasound, they had to transport, and then it would usually be outside the 4-hour window by the time ambulance would get there and then get them out. And so you're sending these acutely dangerous things via POV, oftentimes, because that's the least risky for the patient. But it's just like tensions that you didn't think about managing.
Then we talked a lot about problems. So then what are some opportunities to help address some of these problems? And so first off, I think rural pediatricians do have a good opportunity to impact the local health systems, right? You can run mock codes for your EMS, for the EDs, and help make sure that they're more comfortable dealing with those pediatric kids when they do get sick. The nice thing about being one of the few people in the area is people tend to listen to you because they don't have another opinion to go to, right? They're kind of stuck with what you're telling them is the best way to do things. You can also participate in a lot of the quality reviews. So again, I know it's a burden oftentimes if you feel like you're the only pediatrician participating in all the quality reviews, all the hospital committees. But when you have a strong voice because you are that expert on the topic in the area. And then, all these rural health disparities that we've seen are rife for QI opportunities. And so we have seen good success with studying QI projects that target some of these disparities. So ADHD, when they did this one back in 2005, right, they found nobody was doing formal screeners. They were just kind of saying, oh, they might have ADHD, let's put them on a medicine. By just giving them a short training and telling them that they were checking to use, if they were using Vanderbilt's or other screeners, they saw a huge increase, right? They went from 0 to 21% of the time up to 80 to 100% of the time that they were using these screeners with just a short intervention. It's also easier if you're in a practice with 2 people, 3 people, right? How many people do you need to get on board to make a big change, right? Only a couple. Meanwhile, if you had a bigger center, sometimes there can be a lot of resistance to change just based on the way we've always done this here, and now you're trying to get 30 of us to change what we want to do. So definitely can be room for opportunities there. They also looked at asthma more recently. And so with just, again, using training and making them more comfortable and having access to spirometry, they saw a huge jump from 22 up to 86% of the time that it was being used in like that annual survey. We get the BEPAs in Epic now for asthma. It's just showing how often those were being followed. And then also providing an action plan almost doubled with, again, a short intervention saying that, yeah, we're going to be checking if you use an action plan. So short little interventions like that can have a big impact. They also went down to saying, okay, yeah, we were using stuff, but we saw fewer admissions, down about a third, and fewer steroid courses, down about a third again. So big impacts can happen even from little changes. And it can be so much easier to get momentum locally than at the system level. I want to talk for the last little bit here about telehealth a little bit more and some of the opportunities provided by telemedicine. So we've known that telemedicine is a potential going back to early 2000s. 2004, a lot of the specialties put out their first papers saying, hey, this is going to work for kids and help increase access to care. One of the big benefits of using telemedicine, right, if we have fewer local specialists, but you might have a lot of extra specialists in one of the cities. Maybe they can just be helping out without actually having to travel to those areas. It also can help with some of the electronic health records, right? If you're talking with them directly, you don't have to rely on a middleman always. And if they are talking to the physicians, not just to the families, then you can also help cut down some of those barriers there. One of the other things I talk about is the CME discrepancy. So it can be harder for rural doctors to get involved in grand rounds like this or to be part of lectures, continuing education activities when they are removed from the system. Using telemedicine, right, even telementoring or networking, right, people rural could join this talk if they have the link to it. So those are some opportunities to help target some of those CME disparities and help keep people current in the changing education. We all think that we're good lifelong learners and we're going to keep reading our articles, but it can be really hard when you're on your own to pick out what's important out of the thousands of different articles that are coming out every month. They also show lower cost, better access, and improved patient satisfaction when they are able to use telemedicine in these studies. And we can also see reduced transfers if there can be a hospital-to-hospital or provider-to-provider communication from some of these early triage centers, right? If the ED can talk to an expert locally, they might not have to transfer the kid. If they have a kid with mild DK and can get endocrine line who can talk them through what they need to do, they might not have to transfer that kid to a definitive center for treatment. And here's an interesting quote I thought from a 2015 study. So it said the use of telemedicine to provide acute ambulatory and subspecialty care, acute inpatient care, and perinatal and newborn care is now emerging as a feasible and efficient strategy that results in high quality, cost-effective care. And I think high quality, cost-effective care is one of the big goals we always have. My question then is, why hasn't this fixed all of the problems over the last 20 years that we've had studies supporting telemedicine? I think there's a couple of things that play into that. So one is there's a huge publication bias going on, right? We only publish the studies typically that show telemedicine worked. We don't show the times that it's come up short. I also think that there is still a remaining divide in terms of who has access to communications, internet, and high-speed communications that can facilitate that telemedicine component. And some things just aren't going to be amenable to only deal with talk. You need an exam for some of these things. And that's where having that provider-to-provider communication may be part of the gap to help fill in the needs of the people, because you can have someone who can listen to the lungs or can get them to do certain procedures and then talk to the specialist about it. It might be easier to develop more that can deliver more of that care. And so this gets into talking about telehealth as more than just visits, right? So big push has been in terms of those critical care situations where you need to resuscitate a patient. If the newborn nursery, right, comes out looking at what are we going to do to help that kid in a moment. Also for EDs or people on their way to PICUs from EDs or inpatient units that are deteriorating, what can we do to help stabilize them? And that's where provider-to-provider communication can be really important. I remember when I was in the PICU, Dr. Ward, when he had a kid down in Martinsville coming to us, he was on FaceTime with the providers there, talking them through, okay, here, try this, giving them that positive encouragement that they can do it, right? So feeding into that kind of as a coach, then also giving them some of the techniques they can use to help stabilize the kid and get them ready for transport can be really important. And this can be something that is quick to implement in terms of they just need to call us and we can try and talk them through it. But it's also one of those things that then what do we do for those less acute situations, right, where we can't dedicate all our time to focusing on this? What do we do next for them? And even that, I think you can talk about like VMAP, right? In the primary care office, we can call the psychiatrist and say, all right, we have this kid here, they'll call you back within a day, and then you can maybe help divert some kids from having to go to the ED for their mental health problems or get better guidance on what medicines to start before they can see a psychiatrist. Another opportunity would be in school-based services. So if people at home have trouble calling in, can we maybe get the schools with their internet to facilitate some of the care for kids? That can reduce travel, both for the families, but also the parents, right? If they can be at work, the kids at school, and they can all be on a network conference call, then that often can save people from missing work and missing school. The other thing is some Vanderbilts. How many times do we do an ADHD visit and have the school Vanderbilt form and the parent Vanderbilt form at the same time? Maybe once or twice, right? If you like saw them a month ago and said, here's what we need to do before we schedule the next appointment, have both of you fill it out, right? So it's not easy, but if they're at the school, right, the school nurse can be right there, she can go hand the form to the teacher, send it back to you, and you can often get better compliance with some of those screening things that you can't get without having that school involvement. And then talking more about that telementoring, again, that's where we have more of that provider-provider communication, talking through issues, getting people involved to talk to the bigger network and see what the specialists are thinking, seeing what's important, is a big component that we don't want to forget about. So we don't want to just focus on the care of the patient, we want to focus on the providers as well. All right, so is telemedicine taking off and filling this void? Well, we looked at 2020 data for the pandemic, right? Pandemic, we saw a lot more acceptance both in terms of the legal system as well as in the patient family system in terms of using telemedicine to provide care to kids. And what the study found was that nationally about 17.5% of people had used, or children had used telemedicine in the last 12 months during the pandemic. 14% of that was because of the pandemic, where if they didn't have the pandemic, they probably would have just gone to the doctor or not gotten care at all. And so that's a pretty big jump, right, when we see like 14% of that 17% was due to the pandemic. And so then the question was, so is this helping the people in the rural areas the most? Now, it found that large cities were the ones that had the biggest rise in terms of their telemedicine use during the pandemic. And in many ways, I think that makes sense, right? If I'm living in Roanoke and my pediatrician's, at Tanglewood, I'm not going to think, oh, I'm just going to do a telemedicine visit instead of just going to the doctor, unless we shut down because of the pandemic and we don't want to catch COVID or are scared. So in many ways, that makes sense. What's a little bit concerning, though, is that the use due to the pandemic was lowest in those non-core areas and those non-metropolitan areas. So they weren't necessarily getting better access to the telemedicine compared to cities. Part of that, though, could be that they were already using it a little bit more. When we look at the people who used it the most, asthma was the diagnosis that most people were using who came and got telemedicine. We also saw, though, for anyone with a disability or medical complexity, we're more likely to use telemedicine. And again, that makes sense, right? If you have the kid with CP or asthma, you don't want them catching COVID or another respiratory bug that could push them over the edge and make them extremely sick. And so those are the people that were using it the most during the pandemic. Interestingly, they also looked at income. So the lowest income brackets, people making less than 120% of the federal poverty limit, or the highest income, so earners over 400% of that limit, were the most likely to be using telehealth. So the middle class was the one that probably used it the least in this study during the pandemic. Here's a table that came from there. So again, it breaks it down by use due to the pandemic. And if you look, the non-core areas, only about 7% were using it due to the pandemic, and that 13% that used it in the last 12 months. And so they were using it at a high rate. If you think about it, roughly 6% maybe were using it not due to the pandemic, so they might have been using it already, which is higher than those people in the cities. But we didn't see that big jump there. Interestingly, again, we talked about those maps, how geography can be a confounded to a lot of these rural studies, right? The South uses it the least, and the Northeast uses the most. The Northeast has the most people already and the most providers already. So we are, again, seeing those regional trends in healthcare that kind of can be a co-founder here. Is it the South doesn't use much because they're rural? Because of other cultural barriers? It's hard to say exactly. All right. So then, my question is, is telemedicine the solution? And I don't think it can be the only solution. Some things are never going to replace having that provider-to-provider, face-to-face communication. That there's a lot of talk about the healing touch that we provide. Right, having that provider touch, you can make you much more confident in the plans. But I do think it can help fill a role, especially when we think about it beyond just the patients talking to the doctors, but we think about the doctor-to-doctor communication, as well as in a health system education components as well. We didn't talk about some other things, like access to advanced care providers and things like that, and all those can possibly help fill a role. However, we're also seeing that despite pushes, we often see that a lot of those ACPs and other providers are going into more of the specialty fields besides primary care, or working in more of the cities where financials can be more beneficial to them. So I do have some questions for you guys, unless you guys have any questions you want to jump up first. But I have 3 CME questions we can run through and then maybe discuss. So my first one here would be, rural patients have high rates of all of the following except formula feeding, obesity, dental caries, or on-time well checks. This is an accept question. Seeing these, yep. So on-time, well-time checks. Okay, which is true of rural pediatric firearm injuries? Adults are usually the shooters, most often involve assault rifles, about half the correct home, or homicides outnumber suicides.
C.
Okay, C. And my last one, which group uses telemedicine most often due to the pandemic? Middle class, rural, those with chronic health concerns, or people living in the South? Yeah, those are chronic health concerns. Perfect. All right, here are my references, but I'd love to hear if there are any questions that people have. About, was it 15 minutes or so? Dr. Pierce looks like he's chewing on one.
Well, I got one, but it's not entirely rural medicine, so I wanted to. The telehealth piece is interesting. I think there are many initiatives within our system that they kind of look around on these. You're right, it's not the solution, and particularly, I'll go back 23 years. Steve, if he's out there in the cloud, he might be asleep by now. But if Steve's out there, I'm sure as a rural pediatrician in eastern Montana, he has plenty of time to do telehealth. No, every bit of his time is going to be filled with whatever you can do. Couple of things that are interesting. The one statistic that I find very interesting that comes out over and over, and again, you got to filter who's doing the survey. But I think there's a lot of provider hesitancy that still overcomes, because you look at the number of providers interested versus the number of patients who are interested. I think that's an amazing piece. I mean, it's kind of we got 15 minutes, I'll keep going. You get on your cell phone, you get home and go back to that urban environment. I can get my Uber ride, I can get my chow now, and I can get there. Now I got a cough, what do I do? Yeah, well, they are having options of real-time, on-demand visits. The areas that have really been successful is certainly behavioral health. Pediatrics, we got to be early adapters during the pandemic here at Carilion because we had some use of that. But the developmentalists and behavioral health in particular have been really picking up. Family medicine has piloted and amazingly successful a virtualist crew. And in fact, we're recruiting a pediatric virtualist in conjunction with them to kind of move on that. Interestingly enough, one of the worries was antibiotic use, and it was actually lower when we've used the virtual care than in the in-person visits, so whatever. ER, I'm going to give a shout out to our emergency department. Paul Haskins and his team, they used some telehealth to help triage, and they have an amazing decrease on those leaving without being seen. It's really engaging the patient, getting them where they need to be in areas like that. Again, not the solution, but West Virginia set up a system. This guy, Chuck Mullet's chair, and Morgantown's over on the west side of the state, as is, I'm blanking on where the other West Virginias. But the whole eastern part, we're seeing some of them, but they're starting to build networks with nurse practitioners along with the subspecialist cares to kind of build it out. But so it's an opportunity as we move forward, but it's not the solution on anything. Everything together is the solution.
Right, and I think when it works best, telemedicine, is not when they're getting it from a different health system, right? It's not they're calling the insurance company's person to get the telehealth consultant. It should be integrated with people who have seen them. Yes. The laws need to catch up too. I think that'll help some of the comfort too, right? Right now we have to make sure they're in the state of Virginia and all these rules. Some will relax in the pandemic, but now we have to figure out some of that legal things there in terms of who can we actually be providing care to.
It's not to change that even, which I think makes sense, but I think, home system is important.
Right, and then also the liability piece, feel worried, if I didn't listen to you, can I really make any, judgments on what medicines you should be starting?
Is the compensation adequate?
So that's something that's always been around, right? So oftentimes, especially if it's the Medicaid payers that are trying to use it, they often get lower compensation. But in general, they can be well compensated for telemedicine. Oftentimes the visits are a little bit less in terms of an in-person visit, just because of oftentimes time factor that you can't fill a longer time necessarily if you just didn't listen to them and didn't have that same discussion. But in general, it's a fairly even conversation from what I was seeing.
It's real. And then if you look at
a lot of progress.
Well, and if you make some progress, but then you don't have bricks and mortar, you don't have the staff, you don't need as much staff. The staff can be more centralized locally. So there's a lot of, good thoughts.
How much medical students are exposed to rural health and rural care?
I haven't looked at that in particular. I know there's usually like a rural health interest group at most of the medical schools. I know I had one at my medical school. But, you know, it's one of the things that's harder too, because where are most of the medical schools going to be located? They're going to be located at academic centers, those larger, more localized regional hubs, as opposed to at the smaller sites. My sister went to medical school, though, in a rural area where the population was about 10,000 people. So there are some rural medical schools where people get more exposure, but it's one of those things, too, is are you going to make the medical students drive now hours a day just to go to clinical experiences? Areas that have trouble getting in, a place for them to stay can all be difficult. So there's challenges with getting exposure to the rural health for people, but people who are interested can definitely find ways to be involved.
Dr. Griffin said he can touch on.
Okay, Dr. Griffin.
Are you guys able to hear me okay?
Yes.
Yes.
Cool. So I can touch on telehealth a little bit first, and like Dr. Pierce was saying, having that system backing is probably the biggest thing out here that helps us. We're part of Intermountain out here, and so we have this massive children's hospital in Salt Lake that all of our telehealth comes from there. And probably the most I've used it is inpatient. So they have like tele-neonatology, where there's literally for their system just a neonatologist sitting in a like a telehealth cubicle kind of thing that is doing resuscitation consults, neo consults. Like you call them up and they're there 24/7. We also do a lot of psych admission, unfortunately. So we, you know, when they roll into the peds ED downstairs, you know, for you guys, you have, you know, potentially social worker that can see them, like a crisis team, all this kind of stuff. And so we're it, unfortunately. So we have a actual like telecrisis system where the social worker calls them up, does their triage, the admit, doesn't need admission, that kind of thing. So that's mostly where we use telehealth, is inpatient with the services that we kind of acutely need. You still get the, you know, peds room, teleconsult, stuff like that for the real hard to find specialties, but it's really helped close the gap, especially for a lot of my partners are family med, and if, you know, kids are scary, they want to get those specialists on board to kind of help them out. And then reimbursement wise, not so much for telehealth, but rural health. Reimbursement is actually somewhat higher from my understanding of it to the hospitals, just because Medicaid, Medicare, stuff like that will pay a little bit better because the care deserts are so much out here. So our rural health designated clinic actually gets, you know, for an ear infection, probably a little bit more than an urban population, just to keep the services out here, basically. And yeah, I think that was about it. But telehealth's really helped kind of close the gaps a little bit on that, which has been great. So you're not totally on an island, but technology, if you use it appropriately, can definitely kind of help close some of those gaps.
Thank you.
Thank you so much.
The other piece Steve didn't talk about, but it would be when you do transfer. You know, when we think of fly, we think of a helicopter. I don't know, Steve, are they fixed wing or are they helicopter for you?
So it depends on where I need them to go. My nearest, like, true children's hospital is about either 8 or 10 hours away by drive. So it's either going to be Salt Lake or Denver. So if they need lots of specialty, it's going to be a fixed wing flight, and hopefully they're not too critical, so you can get them there. I have a peds floor and a PICU about 2 hours away, and helicopter is, I think our max flight distance is like 150. I think my hospital's at 149. So if it's a critical kid, they'll kind of like, you know, top off the tank on the chopper and fly out. Otherwise, it'll be fixed wing out. And we have almost nobody goes by ground because we have one ALS crew for probably most of eastern Montana. And if you put them down, then, you know, the heart attack's not getting picked up either. So the transport really tries not to use that.
Different perspective.
Thank you.
All right. Well, then we're going to thank you guys all. Thanks for participating in my word cloud activity. I really appreciate all of that. And it's been fun being here last year. I'm happy to be staying. So.